Thalassemia conference. Hayaa, very big conference as always, and since 13 years we are all eager to wait for this conference every year. This caliber of this chairpersons, and first of all I'd like to thank Professor Amal for this very nice meeting. Always as usual, she's used to give us enormous amount of knowledge. She is always here with her smile, her modesty, and her beautiful way to meet everybody and welcome everybody. And I hope she will be always like that among us. Very much. Thank you so much, Professor Amal, for this invitation. Really, I'm delighted to have Professor Lamis Raga. Finally, I saw her. I miss you very much, Professor Lamis. I miss you so much, and I like always to be with you. I'd like to salute Professor Noreen Adda. I can see her here. And finally, my beautiful chairperson, Professor Monan Taghi. And I think now I have to leave you with Professor Monan Taghi.
Thank you very much. Thank you very much, Professor Galina. Of course, we are very enthusiastic to listen to the very elegant and very scientific talk of Professor Galila. She is head of the pediatric department of Ain Shams University and head of the hematology department of Ain Shams University. The talk will be the kidneys in sickles, always the target.
Hello, I'm here. Okay? Welcome back. And it's me here to speak about sickle cell disease. This is totally different from the rest of the day. And as usual, Professor Amal is always challenging me to give something else. I don't know why, but I'm ready for this challenge. I hope I'll be for this challenge good enough to introduce for you something about the sickle cell disease. The target. This is the kidney, and all you know about sickle cell disease. But actually, I have to give a little bit introduction about it because I think this is the first topic about sickle in this day. So again, sickle cell disease is very important, and it's prevalent as a genetic disorder, and 200 million carriers of sickle cell trait are existing worldwide. Although it is a simple disease, but it is not a simple cure. And I borrowed this from Professor Iman Munir. One day she put this slide, and I was challenged by it that this disease is not as simple as it looks like. And it is definitely a gene mutation. And here we all remember this mutation in the normal hemoglobin being in this way in sickle cell. Valine for glutamic acid, and this very, very tiny amino acid replacement is the cause of the whole condition. Although it looks very simple, but it is not. This is the complication of the disease. Remember, the pathophysiology starts from here. Fever or decreased oxygen. And then ending by here, which is thrombosis. What's in between? What happens in between? In between, we start by this fever, sickling of the monocytes. There is release of interleukin and the tumor necrosis factor, and these adhesive molecules, and these adhesive molecules causing vascular damage, and then after thrombopondin and leukocyte adhesion ending by thrombus. So this is the first process process is this. By the fever and the hypoxia, there will be sickling of the RBCs. These RBCs release on the surface the phosphatidylate serine, and this causes the cell to be more adhesive, again causing thrombosis. So this is the second process. The third process is sickle. There will be destruction. Being abnormal cells, they are destroyed. And being destroyed, there will be anemia. Being with anemia, there is increased shear stress and thrombosis once again. And finally, this destruction causes release of the plasma-free hemoglobin, and the free hemoglobin is nitric oxide, and this causes vasoconstriction ending in thrombosis. So everything collectively ending in thrombosis. And in this thrombosis, there is increased D-dimers, increased protein C, protein S, and thromboactivated thrombin. This is very bad. I don't know why. But here is the process of, it doesn't look very well, but this is the only way. That there is a decrease in the shear of, or there is shear stress, and the condition starts. All of you know what is sickling. We have different diversions of the symptomatology, starting by vaso-occlusive crisis, and here the triggers, and here are the signs. We have the infection, dehydration, cold temperature, and menstruation, ending by dactylitis, acute chest syndrome, spleen infarct, CNS, eye, and priapies. Again, there is hemolytic process, which is not that common and usually initiated by drug or infection or associated GCC. Lastly, the two other crises like aplastic or sequestration with parvovirus or drugs or sequestration ending in acute damping, hypotension, and sometimes causing death. This is the usual what we know about sickling. But here I'm targeting only the kidney. So the kidney is the target, and we have many renal manifestations related to the sickling. First of all, we have to know the epidemiology. The epidemiology always, as pediatrician, we don't see a lot of renal trials because sometimes they present later on. The average or the median age is 23. This doesn't mean that it doesn't happen early, but because they are delayed in symptomatology, sometimes they are later. And here is always the vicious circle by the RBC sickling and the stasis, the organ damage, the hypoxia, again causing sickling, and so on. Or in the kidney, there is acidosis causing more sickling, stasis, and so on. So it is always like a vicious circle. In the kidney, causing this kind of sickling in chronic sickling. The pathophysiology is very, very complicated. No one can tell what happens all over the kidney. Everything can happen, but this is in brief, just in brief to say. In the renal medulla, there is a hypertonicity with acidosis, low oxygen tension, leading to increased blood viscosity. There will be functional venous engorgement with interstitial edema, renal ischemia and infarct, rupture of vessels, and hematuria. This is number one in the pathophysiology. And number two, there will be secretion of vasodilated prostaglandin. In one way, increasing glomerular filtration rate. On the other hand, there is hypertrophy, glomerulosclerosis, and decreasing glomerular filtration rate. So as if two factors are competing each other, and there will be derangement in the glomerular filtration rate. Besides the pain that exists at that time, and the patient is taking a lot of analgesic, we are endangering again the kidney and causing nephropathy. The pathology is glomerular plus medullary. And you can see here the glomerulosclerosis, the non-immune mesenteric proliferative, the edema in the medulla, renal capillary necrosis, and this is what about the hemosiderin and the microinfarct interstitial fibrosis. Why I'm saying this? Because for a long time, we don't consider that the hemosiderin in the kidney represents any threat. But now we have to focus upon this and say that the hemosiderin, the iron deposition in the kidney, is another clue to diagnose and to treat by giving the chelator. This was not in our minds before. And here is the papillary necrosis as evident by this patient. What is the renal manifestation? There is a lot of the renal manifestation. There is proteinuria, renal tubular acid, blood pressure, and renal failure, urinary tract infection, milk concentration, and hematuria. Let's take some of them. Not every one cause, but there is many we have to be directed to. For example, the hypothenuria. This is failure to concentrate urine. There is excessive loss of water by this, and there is defective metalloelectrolysis. In sickle cell disease above the age of 10, the urinary concentration is often reduced to 400 milliosmol of water. The hematuria. The hematuria sometimes is very asymptomatic, and we don't even look at unless the mother is complaining of it. And there is something related to the left kidney more than the right kidney, perhaps because of the vasculature of this side, and it is self-limited. The proteinuria, and here there is glomerular affection. It presents in 30% of patients during long-term follow-up. And the nephrotic syndrome is found in 40% of our sicklers, and if we find at any time nephrotic syndrome, we may proceed into chronic renal failure. And this is very important because sometimes we see hematuria, it doesn't matter. But if there is a nephrotic syndrome, this matters a lot, and this means the continuation to the renal failure. The renal tubular acidosis, this is a proximal hyperfunction with increased loss of sodium and phosphorus, and the myotubular acidosis may present at any time. This may be later, but early the proximal tubular dysfunction is seen rather than late. Very important for the blood pressure. The sickle cell disease, usually they are hypotensive. They are hypotensive because there is renal salt losing. If we find that the blood pressure is normal or above normal, this means already he is hypertensive. So he starts by lower blood pressure and it increases until normal, and then after as hypertensive. The blood pressure again is alarming, and it may end by end-stage renal failure. Acute non-oliguric renal failure, it occurs due to concomitant infection and intravascular hemolysis, and we will again stress about the nephrotic and proteinuria being one of the alarming signs for this. Is there any relation with cancer? Yes. In sickle cell disease, there is a relation to renal medullary carcinoma. كان في بروجكت بنعمله على vaccine in sickle cell disease, and they said that in all over the world there was a case complaining of having malignancy, and this may be related to vaccine. I said no. In sickle, there is possibility of having renal carcinoma later on. Although this is not in the pediatric age group, it is about the age of 25, but still there is a probability of renal carcinoma. Why? Because they correlated the chromosome 11 with, the beta globin is on chromosome 11, and the same for the malignancy, so considering that they are one and the same. And again with chromosome 3, and this correlation was evident all over the world, and here is the renal carcinoma. It is not always impejatic, but it is alarming. So here is the age. In this very young age, polyuria exists and proteinuria exists. And reversible hypotenuria can exist from the very beginning. And later on, there is acidification defect and gross hematuria. And then after the medullary carcinoma, an irreversible state of hypotenuria and end-stage renal failure. So it doesn't exist at the same time, but it is always alarming. Hematuria, you have to follow. Nephrotic, you have to follow. Blood pressure, you have to follow. And finally, the hypotenuria and end-stage renal disease. The diagnosis, as all of you know, everything about the chemistry. We heard a lot about the electrolytes, uric acid, potassium, calcium, phosphorus, bilirubin, and serum statin, cystatin, and the NAB, which is the glucosamidase, and the beta-2 microglobulin and the renal calcium. All these are tries to grasp one marker for the affection of the kidney. They did a lot. They did many invasive and non-invasive trying to prove it. But finally, the important thing is urography and peri-abdominal sonar and cystoscopy, which is a little bit invasive. And here is the sonography revealing the kidney affection. But we had to look in another way about what is hemosiderin, what's causing the kidney, is it the tubular defect related to this or not, is it related to hemolysis, is it related to the duration, is it related to splenectomy? Yes, we did. Magnetic resonance imaging to find the renal affection in sickle cell disease. And you all know about the magnetic resonance, which is very important now in quantitating iron. And we had to work aiming to find out the deposition of iron in the kidney. This is the mess. It looks like very tiny, but bearing a very big shoes. How to treat this, we don't know. Here are the subjects and methods, and we use this as inclusion criteria, being more than 5 years sickle cell patients with serum creatinine less than 1.5, and the creatinine clearance more than 90 with no comorbidity. Trying to find that the only thing here is iron deposition. We got all the medical history examination investigation with the magnetic resonance imaging. What did we find? This is the result of normal. Here is the normal kidney, here are the normal kidney, and here are the abnormal kidneys. And there is renal parenchymal deposition and decreased alarming amount of the iron deposition. And we can find that this is related to LDH. How? Again, the mean intensity of this one, control, and case, and this is control, and here is the decrease of the MRI as evident by iron deposition. LDH always denotes hemolysis. We found a correlation between the intensity and LDH, meaning there is iron deposition. Again, there is increased inverse relation with the duration. When the duration increases, the intensity decreases. Again, there is a correlation with splenectomy. You know the splenectomy means more deposition, more hemosiderin, and again it is related to it. And there is statistical significance between them. The duration of illness and the splenectomy and LDH all conclude that the MRI, being sensitive way to discover the hemosiderin and for follow-up and for complication detection, increases with LDH, with the renal deposition and renal pathology in those patients, and sickle nephropathy is an important cause of mortality. Chronic sickling promotes different mechanisms of of kidney injury, and the clinical detection of manifestation of this process is very important. Detection for the risk factor for medullary carcinoma is very important. And finally, this sickle cell is saying, thank you, wishing your RBCs the best. Thank you.
Thank you very much, Professor Galila, for your excellent talk. I think we will postpone the questions to the end of the session. Okay.
Thank you, dear Chairperson Professor Mona Taghi, for allowing me to introduce the next speaker. And the next speaker has a special name for me, and she is trying to put it as a tag. I always tell her جميلتي. فجميلتي هي اللي هتقدم دلوقتي بروفيسور منى حمدي. جميلتي هتقدم intrafamilial transmission of hepatitis C infection in Egyptian multi-transfused thalassemia patients.
Thank you so much, Dr. Gillian, for such a good event. Hepatitis C virus infection causes chronic hepatitis in over 50% of cases. It ultimately leads to severe liver disease, cirrhosis, or even the development of hepatocellular carcinoma. The prevalence of hepatitis C virus in multi-transfused beta thalassemia varied a lot among different societies. These were the three main studies we had at our hematology department at Cairo University. We had the prevalence of hepatitis C varied from 50.7 to 74.2 among different studies. Same as in India, where they had wide variation from 11 to 68. The extreme degree of variability of hepatitis C virus seroprevalence among multi-transfused thalassemians depends on two major things. First of all, the prevalence of HCV in the relevant population, and therefore also in blood donors. And secondly, the practice of HCV antibody screening before the transfusion is initiated. The introduction of screening for this virus by the year 1992 has greatly reduced the post-transfusion transmission. The risk of post-transfusion transmission has significantly declined to be 0.001% per unit blood transfused, and every 100,000 transfusions in the United States. Further decrease was observed by the application of the nucleic acid amplification testing, the NAT, to reach 1 per 500,000 transfusion exposure to mechanical reactor. In Egypt, although there is application of blood screening and decline in the prevalence of transfusion-transmitted disease, blood transfusion is still the most common cause of HCV infection. A large proportion of patients who had not been exposed to any of these risk factors of blood products were found to be infected with the HCV. In these patients, intrafamilial transmission of the virus was suspected. Mechanisms of intrafamilial HCV transmission varied a lot, starting from the percutaneous exposure to contaminated household items, the use of objects contaminated with saliva, and their molecular evidence of the HCV virus replication in the oral mucosa, in the sweat glands, and in the peritonium. Factors involved in HCV intrafamilial transmission. First of all, which is the major factor, shared use of personal hygiene items like toothbrushes, razors, scissors, increase in the number of family members. Whenever there is an increase in the number of family members, there is an increase in the percentage of the cases. And rural versus urban areas, where it's more common in the rural areas, and higher maternal transmission. This was the largest study done in, among rural areas in Egypt, taking the Delta and the Upper Egypt in Asyut. where they were testing the transmission of hepatitis C virus between parents and children. It was observed that mothers having RNA positive gave a high prevalence of 14%, rather than the fathers, where it was only 9.3%. And then this was the general prevalence. And then they tried to make sure that it's only from one person contact. So they took the fathers with the known mothers to be negative, HCV negative, and they tested them. And also they discovered that those having RNA positive had a prevalence in the children of 5.6, which still was lower than that observed when the mother was HCV positive and the father wasn't. Still, the mothers were higher, definitely. The aim of our work was to investigate the current prevalence of HCV among Egyptian multi-transfused thalassemics and to evaluate the risk of HCV transmission between patients affected and their household family members within the families. The patients there were 137 multi-transfused Egyptian thalassemics following up at our hematology unit. They had a mean age of 15.7, together with their family members who were all tested for HCV. Testing for HCV was mainly based at first by checking the antibodies by the enzyme immunoassay. Those who tested a positive antibody were then retested for the viral load by using the PCR. Family members were asked to answer a full questionnaire for the risk factors of HCV transmission, and the contacts of positive cases were examined and were compared to contacts of HCV negative cases. HCV genotyping was performed for HCV positive patients and their families to prove the relationship. Our results show that 47 cases out of the 137, about 34.4% were HCV positive by both antibody and PCR. This was the largest and the latest study we had at our unit by Professor Denis Ragab, in which the prevalence of HCV antibody was accounting for about 68% of cases. The 49 were completely were HCV positive, while the other 19 were HCV and HGV positive. On comparing the HCV positive cases in relation to the negative ones, we observed significant values. The positive group had a higher age, higher ferritin, higher higher AST also, and the duration of transfusion, the years of transfusion was markedly higher than those who were HCV negative. The questionnaire we did proved that using the hygiene items was very common among our family members. Then the 47 positive cases, we were able to test 24 of them. 24 families of these cases were tested, about 73 members, and among these 24 families, 11 families showed positive HCV. So these 11 families accounted for about 45.8, almost 46% of those families of HCV positive cases that were proved to be positive. On the other hand, the other group, the negative, the HCV negative group, we were able to study 27 families of them, about 82 members, and seropositivity was evident among 3 families only, accounting for 11% of the total examined families. So this is our results. This is the prevalence of the HCV among contacts of HCV positive patient and HCV negative. Among the HCV positive patients, it was 19.2% versus 4.9%. So it's only almost 4 times among positive versus the negative patients. HCV prevalence is reported to be from 2 to 10 times higher in family members of HCV-infected patients than in the general population. It is possible that intrafamilial transmission occurs as a result of inapparent percutaneous exposure to contaminated household items as razors and toothbrushes, handling the needles and syringes used by the infected person, and handling the blood of the infected, especially with frequent and prolonged contact. Going through the literature, this is the general prevalence of HCV among contacts of HCV positive and negative patients. These studies were mainly on hepatitis patients. The one in Pakistan, it was among Thalassemia hepatitis C positive patients, where they found a percentage of 20.5% among the contacts of HCV positive cases. In Israel, we had a study comparing the seropositivity of contacts of HCV positive, which was around 4% versus 0% among contacts of HCV negative. And in Iran, it was 2.5 contacts of HCV positive versus 0.7 among contacts of HCV negative. In Italy, a prevalence of 2.5 among the HCV positive cases. The percentage of HCV affected family contacts of the HCV positive patients, we observed that the seropositivity was the most common among the brothers, accounting for around 30%, and followed by the mothers around 24%. And increasing the family members showed great significance among the increase in the prevalence of HCV among our contacts. Genotype, we were able only to do genotype for 7 families out of the whole study families, and the 87.4 of the study group was completely identical to the contact patient among the family members. Our conclusions were that household contacts of HCV positive patients have elevated risk of HCV infection in areas with a high HCV prevalence and thus a large reservoir infection. The risk of incident infection should be relatively high, increasing the importance of and opportunity for the identification of current risk factors for transmission. Learning the mechanisms by which HCV transmission is occurring between family members so that preventive measures can be initiated is of utmost importance. Thank you.
Thank you so much, Professor Mona Hamdi, for this talk. والحقيقة هو في حاجتين أكبر حاجة ناشونال ستادي عملها على فكرة الدكتورة منى كان الدكتور مصطفى كمال، والدكتور مصطفى كمال هو professor of social medicine. Unfortunately, he passed away because of hepatocellular carcinoma and probably because he was exposed to this. Number 2, for the national campaign against hepatitis C, I remember Professor Manal Hamdi Said, she was talking to us every day about this, وكان ليها تحفظ مش بس الباد sanitation هي اللي ممكن تكون the cause of this transmission، لا ده كانت بتقول sometimes the good sanitation، بس تستغرب بقى هي ال good sanitation اللي هي ال common أو ال public tubs or bath، الأماكن الحمامات العامة اللي هي بيستخدموها في أماكن معينة كلهم together عشان to take a bath in it. Sometimes this is very bad, although this should be good sanitation, لكن actually it was a bad one. واستخدام كانت it's not the sponge اللي بنستخدمها in Egypt، لكن كانت الليفة. الليفة دي ممكن انها تبقى واحدة من الأسباب اللي بتعمل transmission، للانفكشن through crashes او through scratches in the skin ممكن تنقل من واحد للتاني. فيعني الحاجات الغريبه اللي كان واحد بيقراها عن الهيباتيتس سي. Now I think I have the honor to introduce the next speaker. لكن الحقيقه قبل ما انقل للnext speaker يعني انا اتشرف بان انا بعمل في مكان يعني في lot of calibers و lot of calibers كلهم hepatitis كلهم minded with hepatitis